Good evening, everyone. I am Dr. Sushrit, MBBS MS General Surgery, and today we'll discuss the Baveno VII guidelines related to clinically significant portal hypertension. So, by definition, clinically significant portal hypertension is now defined as more than equal to 10 mmHg of hepatic venous pressure gradient, and HPPG is the gold standard for the diagnosis of clinically significant portal hypertension. Another parameter to rule in clinically significant portal hypertension would be liver stiffness measure of more than equal to 25 kilopascal. And a simple way to rule out CSPH would be LSM of less than 15 with platelets more than equal to 150,000. The intermediate zone between the two requires further testing and follow-up. So in presence of clinically significant portal hypertension, there is a high risk of first decompensation. Platelet counts act as a surrogate marker, while falling LSM over time with treatment signify improved prognosis. So primary prophylaxis of decompensation, compensated cirrhosis along with the CSPH. One should start non-selective beta blockers, and these are now regarded as disease modifying drugs, and the most preferred drug would be Carvedilol. LSM of less than 15 with platelets of more than equal to 150K, that is no clinically significant portal hypertension, requires no endoscopy for further screening. For LSM more than equal to 25 kilopascal, no screening is required, as the patient should be treated as clinically significant portal hypertension. For intermediate risk patients, endoscopy is required. So for the management of varices, if the patient are having small varices with clinically significant portal hypertension, non-selective beta blockers should be started. Medium or large varices require non-selective beta blockers or endoscopic variceal ligation. If NSBBs are not tolerated well, EVL should be done, and after eradication, NSBBs should be continued if the patient is able to tolerate them. For decompensated cirrhosis and clinically significant portal hypertension, for patients with ascites, non-selective beta blockers should be used with caution. In case of refractory ascites, reducing or stopping NSBBs should be considered. Patients with AKI, sepsis or hypertension, non-selective beta blockers should be temporarily stopped. Tips in portal hypertension. For recurrent variceal bleeds, early tips in high-risk patients is indicated. For refractory ascites and portal venous thrombosis, tips can be considered if suitable, and tips is contraindicated in cases of right-sided heart failure and pulmonary hypertension. For patients with portal vein thrombosis, anticoagulation is recommended. With the chronic complete portal vein thrombosis, individualized approach should be taken for each patient. For pre-transplant patients, anticoagulation is encouraged, and non-selective beta blocker should be continued if stable. For viral hepatitis with sustained virologic response, CSPH may regress with specific treatment. Alcohol abstinence decreases the portal pressure. In cases of NASH, CSPH may persist despite fibrosis regression. For follow-up, serial LSM is useful for the monitoring, and platelet trends are prognostic. CSPH regression is not an equivalent for cure for the disease, and continued HCC and portal hypertension surveillance is required for these patients. So in summary, liver stiffness measure of more than equal to 25 kilopascal is equivalent of clinically significant portal hypertension, and beta blockers, non-selective beta blockers, preferably Carvedilol, should be started. They're not only preventing first decompensation but also disease modifying drugs, and endoscopy can often be avoided. Thank you.